Good morning, all. At the offset, I want to thank Dr. Hazra, CSI West Bengal team, and my good friend Anmol for giving me this opportunity. I also want to take just a second to express my condolences for the horrific accident that happened last night, where a lot of our fellow countrymen lost their life in train accident at Orissa. With that, I'll start my today's discussion. This is aortic valve replacement in asymptomatic severe aortic stenosis. And I think this is a very relevant topic in the current era of low risk AVR, be it surgical or be it transcatheter. And are we good? Okay. And just for the sake of discussion, in the spectrum of structural valve disease, this is stage C1 that I'm referring to today, which is asymptomatic severe aortic stenosis. We all understand the pathophysiological and hemodynamic implications of severe aortic stenosis, all at the level of microvascular, myocardial, as well as the aortic level. I won't go into the details of it. Now, the current modalities of when to approach or when to offer therapy relies on symptoms. And as you look into the cascade of the progression of severe AS, you see symptoms is one of the very late findings, and a lot of damage has occurred before that. That's probably one of the reasons why even after AVR, these patients, they do not live, they do not match their age-matched peers in terms of their longevity and also in terms of their outcome. And that's probably the reason why we should start looking at, can we intervene early on these patients? When you have patients with severe AS in your clinic, about 50% of them will not report any symptoms at the time of diagnosis, but are they truly asymptomatic? They typically present in two different aspects. There may be a gradual decline in function status. So they may pretty much adjust to it, thinking that it is their normal aging rather than a disease. Remember, AS is a very unrelenting, it's a very chronic disease. And you know, when you grow, let's say 60 or 70, you don't have an experience of how it feels to be 70. You think it's all aging when it is not. We all follow the very age-old dictum that Dr. Braunwald and his colleagues initially described in 1968, where the onset of symptom was pretty much addressed on. You understand, it's a study from 1968, it's a postmortem study with about 64 patients. And remember, at that time, we didn't have echo. So we really don't know what we are getting into. So what we do these days is for asymptomatic severe AS, at least what the traditional practice had been, is to do watchful waiting. May not be the best option in the modern era. We know that eliciting true symptoms are very difficult, as I elucidated earlier. Longitudinal follow-up is flawed. We don't know when to bring them, how frequently to bring them, when they come up to the clinic, what to do with them. Should we keep asking symptoms? Should we do some investigations? Progression of AS is unpredictable. There is a certain cardiac death risk, the annually rate of which can go up to 3%, maybe even higher in high-risk subset. Any intercurrent illness, they get COVID, they get UTI, they get whatnot, that lands up into cardiac ICU, that cannot be asymptomatic. Surgical risk is age-dependent. You do AVR at age 65 versus you do AVR at age 75. There is a lot of difference between the two. Definitive therapy later do not match the longevity that you expect, and watchful waiting is associated with higher mortality. This is a more contemporary data where you see that all these patients with severe AS who are asymptomatic, if you watch for them for the symptom onset, 75% event rate over 5 years. That is definitely different than what Braunwald curve showed. So if you look at these observation versus surgical, early surgical AVR in an unselected asymptomatic severe AS patient, observational arm is associated with 3.5 times higher mortality. Now, these are unadjusted, these are observational data. I'll show you some of the randomized data as well. So when should we offer therapy? Symptoms may be too late, but too early, now we have got surgical risk. So how do we find the optimal timing? And this is where some of the indices, they do help us. Treadmill test is a very good tool. If we know there are concerns associated, but we also know that those asymptomatic patients who fail TMT, there is 6-fold increased risk of mortality in those patient subset. There are treadmill protocols which are established, which are available. I won't go into the detail, but you can incorporate that in your hospital, in your practice, and you should be able to elicit some of those symptoms, which can help you dictate which patient should go for early AVR. We can also differentiate severe AS from very severe AS, and these are the patients whose aortic Vmax is more than 4.5 or 5. And there is now reasonable data to suggest that very severe AS have very high incidence of sudden cardiac death, maybe higher than 3% per year. And with the Vmax, you can also get aortic valve area or indexed aortic valve area with less than 0.4 centimeters per meter square, definitely associated with much higher incidence of sudden cardiac death. These classification can be very easily made through your routine echo assessment. Recent recovery trial, which was published a couple of years back, that showed that when you do surgery in these very severe AVR who are technically or quote unquote asymptomatic, it is leading to a much better outcome as compared to those patients whom you choose to go for traditional conservative approach. Along with the Vmax or the aortic valve area, you can also look for valvular arterial impedance. There are established formulae of how to calculate that. And more than 4.5 millimeters of mercury with the indexed data, it is associated with worse outcome, and these patients should be offered early therapy. We all have learned how to look into the flow state. We establish patients on normal flow or low flow state. All those patients with severe AS who are in low flow state, they tend to have much worse outcome. And these are the patients who benefit the most with AVR. Ejection fraction, while we consider 55 or 60% as a normal ejection fraction, there is evolving data which suggests that ejection fraction less than 60% may be attributing to early myocardial dysfunction in those severe AS patients. And the rate of progression of severe AS is another marker. If you do end up longitudinally following these patients, and if their AS progresses more than 0.3 meters per second, that is the aortic velocity per year, they may be early progressor who will benefit from AVR. Aortic valve calcification has become a very routine tool in the CT tower protocol where we do, and there are cutoffs which are defined. They are kind of arbitrary cutoffs, but it does get the point across that patients whose valve are severely calcified, even if asymptomatic, they tend to have worse outcome. Global longitudinal strain and myocardial late gadolinium enhancement on MRI, they all are surrogate to show that there may be early myocardial involvement in severe AS patients who otherwise are asymptomatic. There are various cutoffs defined for GLS and also for myocardial fibrosis on MRI with a T1 mapping where the highest T1 tertile associated with worse outcome. So all these criteria, even in the absence of symptoms, tell you that the myocardium is asking for help, and we should be offering therapy on them sooner. There are other high-risk features, which includes biomarker positivity and many other entities which are less well validated. There are evolving data set which are coming in a randomized fashion, which are looking at the role of early TAVR, a low-risk AVR procedure in these patient subset, whether that is going to improve the clinical outcome or not. So as for the guidelines are concerned, in asymptomatic severe AS, if they are going for any kind of open chest wall surgery, then if their EF is less than 50%, any concurrent surgery, you should go for aortic valve replacement. That's a class 1 indication. All others criteria that I mentioned over here, some of them made it to class 2A indication, but as a general, they are still not strongly recommended for the lack of randomized data. All the values that I have presented to you have been summarized in this table. These data set, as I said, a lot of which are validated, but has not made the class 1 recommendation yet. I quote a phrase from a surgeon from 1965, that if you have a low hospital mortality with AVR, it can justify a policy of doing surgery early. So it's not a matter of that severe AS asymptomatic is not bad or it is acceptable. It has to be matched to the surgical mortality that is there in your hospital. And if you are able to offer a low-risk AVR, I'm not talking particularly for TAVR, if you're able to offer a low-risk AVR, which can beat the sudden cardiac death risk that an asymptomatic severe AS patient has, it may be worth going for it. So I would summarize my discussion by saying that please beware of the mask symptoms. Take help of all these ancillary tools that I have mentioned over here. AVR in asymptomatic AS is allowed in certain subset that I mentioned. And if you can perform AVR in your hospital with low perioperative mortality, it may be a way to go. And there are trials underway where TAVR, which has established itself as a very low risk AVR in this subset, may be the way to go, but we have to wait for the data. Thank you so much for your kind attention.